Thank you, Laura. So thank you for inviting me to be here, and thank you everyone for joining this call. I've tried to make this lecture one that would be adaptable to those who are senior intensivists. I see some of you on here who have a lot of experience. I hope this will be a refresher, as well as be adaptable to be an introduction for people for who this may be some new concepts. Many times when this lecture is given, it's often a lot of lists, and I tried to avoid that. What I'm going to try to do is impart to you a framework and some concepts to try to think about shock and how you may treat it. And so we'll look at what is shock, what are the different phenotypes, and then how you can apply that physiology to pharmacology and design a strategy at the bedside for your patient. So what is shock? We have to think about shock as a syndrome. It's a dysfunction in terms of metabolic, cellular, and circulatory phenotypes that are a final common pathway that result from critical end organ malperfusion, hypoxemia, and ischemia due to circulatory failure. And that failure can be for any reason, whether it's insufficient blood volume, insufficient ability to pump the blood around, or an insufficient arteriolar constriction and lack of SVR, such that there's a decrease in effective circulatory volume. The manifestations of shock are protean and subtle. So there are many different ways, we'll see on the next slide, that this can manifest systemically. What's going on in the cell is that lack of energy means that the cell cannot regulate its ion and pH and fluid balance. That results in local endothelial dysfunction, mitochondrial death, coagulopathy, and inflammation. And the inflammation is one of the things that leads to circulatory failure by releasing vasoactive, vasodilating compounds. So when you're suspecting shock, you have to realize that it's time sensitive, that it's life-threatening, and the manifestations sometimes are not very overt. For example, hypotension is not always present. I also always think, what's my patient's normal blood pressure? If you have a patient who lives normally at a systolic of 180, they could be in shock at a systolic of 140, but you wouldn't pick that up on an epic vital sign sheet without thinking about it. Untreated shock leads to multi-organ dysfunction, which is an irreversible hemometabolic syndrome. So it's our job to think about shock before the compensation mechanisms are exhausted. So here are some of the things you might think about. And again, you're thinking that this can affect any organ system. You're looking for any perturbations. So you can see levels of consciousness decreased, tachycardia, tachypnea, reduced oxygenation. Oliguria is a sign I always look for. You're looking at the extremities. Are they cool, clammy, clamped down? Do you have libido? The cool and clammy is because the SVR is going up as a compensatory mechanism. Now, of course, the star is there because that doesn't apply in septic shock, which is defined by a vasodilatory state. Cap refill is another parameter that you can look at. There have actually been randomized trials of cap refill versus lactate in assessing shock. You can see manifestations in the GI system, in the blood, for example, thrombocytopenia or DIC. And then here's some parameters of hypotension. In guidelines and books, you'll see a systolic of less than 90 to 100, but I always like to think about my individual patient. What's their normal systolic and have they deviated from that? You can look for changes in the mean arterial pressure and pulse pressure. Some of these are crystallized in scoring systems. So one is called the SOFA system, and I put the little green SOFA by the green ones that are the 6 parameters there. So it's level of consciousness, oliguria, PDF ratio, thrombocytopenia, increased bilirubin, and hypotension. And then there's a quick SOFA, which is just dependent on hypotension, tachypnea, and level of consciousness. So what types and etiologies of shock can we see? I think far and away in COVID, what we're going to see is septic shock. And so what I want to try to impart to you is what is the physiology of each type of shock and what are the different manifestations and etiologies of it. So septic shock is really defined by a failure of the arterioles to maintain SVR. That translates into an insufficient preload because all that blood is pooled in the periphery. And the etiologies that you will see are septic shock, infectious, as well as non-infectious, which can be of a number of different types, anaphylaxis, endocrine failure, and whatnot. I want to comment on some of the definitions of sepsis. This has evolved over time. There are multinational consensus groups informed by data in terms of prognosis and outcome. And so when we use the word sepsis, what we're really saying is that the host has an aberrant response to an infection and there is some evidence of organ dysfunction. Note, hypotension is not part of that. If you have the syndrome of sepsis and you've resuscitated the patient with fluid, you had Dr. Frank's lecture yesterday, and you have evidence of malperfusion in terms of hypotension and lactate, then you can call that patient septic shock. And these two categories correlate with different mortality outcomes. So we have sepsis, which is an infection response, septic shock, which is the hemodynamic consequences in the setting of sepsis. The other type of shock you might see in COVID is hypovolemic. Patients may be hypovolemic if they had a presentation which was characterized by insufficient oral intake or nausea, vomiting, and diarrhea. You can have this manifestation of shock generated from other reasons. Some of you may be in surgical critical care where you see it in third space in trauma or hemorrhage. There's other ways to lose volume. The primary modality of failure here is insufficient preload. The body tries to compensate by increasing SVR. It also tries to compensate by increasing cardiac output, but of course, because of the low volume, the overall cardiac output is insufficient. The last two big categories you will see will be a failure of the central pump or the heart. And so one of those flavors is cardiogenic shock, but there's an actual failure of the left ventricle or the right ventricle to generate pump power. That can be generated also by a valvular problem, an arrhythmic problem. And then the other way you can have that happen is the heart myocardium is working, but there's some obstruction, whether that's aortic stenosis, pulmonary embolism, pneumothorax, pericardial tamponade. Sometimes you might see it in auto-PEEP or abdominal compartment syndrome. So what I've tried to circle here in red are what are the things we think we're seeing in the literature from COVID. So septic shock seems to be very common. You've read about the cytokine storm, and so other syndromes like macrophage activation and HLH. So you may see some vasodilatory shock like that. You'll probably see some hypovolemia. People are doing IVC ultrasound to comment on that. And certainly in our experience and others, we're seeing reports of an acute cardiomyopathy. I don't like the word myocarditis because nobody's proven that there's actual histopathologic myocarditis. So what we're really talking about is acute LV failure. That may be a septic cardiomyopathy, so that may be something to see. And then more and more reports are coming out about coagulopathy in COVID, so PE is certainly possible. What do we know about shock so far in COVID? So I put together this literature scan, and it shows you a very heterogeneous experiences from all over the world in terms of sample size and age. And what I tried to call out is what fraction of patients need a vasopressor. So if you just sort of look from the top of the chart to the bottom, it seems like the rates of vasopressor use and shock in the Chinese series are low. There's not a lot of definitions in these papers in terms of methodology or supplemental indices. If you look more at the ones from the United States, you see higher use of vasopressor in these cohorts. And at least the New England Journal paper from Seattle ICU, the third line from the bottom, tried to comment, was this related to sedation and peri-intubation or not? And of their patients, they found only 14% needed pressors due to the intubation and sedation. 82% had some longer standing duration of vasopressor use, which they thought was related directly to COVID-19 and its effect on the SVR. You have this other series from Cornell, and they had, of all their patients who were vented, pretty much if they were vented, they were on a vasopressor. Now, that may be in part related to sedation use to achieve ARDS-NET goals. We don't know. And in our early experience at MGH, we have a very similar number. So of the first 66 patients who were COVID ARDS patients in the ICU, 95% of those also needed vasopressors. Actual data on the doses and the actual drugs are not yet available. So how do we treat these patients with shock? So you had a nice lecture from Dr. Frank yesterday, which I watched, and our goal is to individualize treatment, assess fluid responsiveness, but be conscientious and judicious about exogenous fluid in a patient with ARDS and leaky capillaries. Once we cross this threshold and we need a vasoactive agent, I'd like your job to be to think about what kind of shock is my patient presenting with? How can I best fix that derangement? So select your drug based on the pathophysiology, which we're going to go over. You're then going to set a MAP goal, which in most experiences is going to be 65 millimeters of mercury. There have been many trials of higher MAP goals. They generally don't improve outcomes, but they do increase things like arrhythmia. So you're going to set your MAP goal, continue to reassess your patient, as well as all of those markers of perfusion and shock, and titrate to your targets. We're probably going to use pressors earlier to avoid fluids. And if you're having a patient in your ICU, most typically you're going to involve a radial arterial line for continuous blood pressure monitoring, and mostly you're going to be administering these medications via central access. Our recommendation is to use the left internal jugular vein if you can, as opposed to the right, just in case this patient ends up needing an ECMO cannulation, and you can save that right internal jugular access for ECMO if needed. So there are many different ways we can interact with and perturb this system of deranged physiology. So two of the ways are alpha and beta receptors. These are catechols, which means they're a family of compounds that come from the adrenal gland. So alpha receptors generally affect smooth muscle tone. Beta-2 receptors in the peripheral vasculature are actually vasodilating, but beta-1 receptors on the heart can have other functions. There are other pathways we can interact with. Vasopressin, we can directly interact with phosphodiesterases, and there are even some other drugs that can affect nitric oxide synthases. This is probably one of the mediators of hypotension and sepsis, causing a peripheral vasodilatation. So here's the dreaded table for this type of lecture, and I've tried to pare it down, and I really want to convey big concepts. So first thing is most of these drugs are actually endogenous compounds or derivation of endogenous compounds. So dopamine is actually converted into norepinephrine, which is converted into epinephrine in your own body. So these are all natural versions of catechol. Phenylephrine and dobutamine are synthetic derivatives very closely related to them. Milrinone is synthetic, and vasopressin we know comes from the body as well. But vasopressin acts on a totally different axis than any of the catechol drugs. So what we need to break these down into is there are drugs which primarily act on alpha and therefore exert a vasoconstricting effect, hence they increase the SVR. Vasopressin also increases SVR, but on a non-catechol or a vasopressin 1 receptor. The next class of drugs do increase alpha tone, but they come with an increase in beta tone as well. And so our workhorse here is norepinephrine, which has a good profile in terms of vasoconstriction, but it also comes with a little bit of beta-1 input. Beta-1 receptors are on the heart. They can increase heart rate, and they can increase inotropy, or the strength of cardiac contraction. Dopamine and dobutamine, they have, all drugs do, but these two in particular in clinical use, they have different receptor profiles based on their dose. So I didn't put the units in here, but these are micrograms per kilogram per minute. And so when you use dopamine at a low dose, it tends to hit dopamine receptors, which are found mainly in vessels like cerebral, cardiac, splanchnic, and renal. And then as you increase the higher dose, you tend to get more of a beta-1 or inotropic effect. And only at very high doses would you actually get a pressor or an alpha effect. Dobutamine is a potent beta-1 agonist, so it's really good for chronotropy and inotropy, though it does have some vasodilatory effect. And depending on the relative balance of these in your patient, you may get hypotension or you may not. And milrinone acts in a different way. It inhibits phosphodiesterase 3, which breaks down cyclic guanylated peptides, and so that's downstream of receptors like epinephrine, which use a 7-membrane G-coupled protein receptor. So it just sort of short circuits and goes around there. What you want to do is develop an idea of what the flavor of each of these drugs are. So phenylephrine will generally increase the SVR. Dobutamine is a very potent increaser of cardiac output and heart rate, but it can have a lowering effect on the SVR. Norepinephrine has a balanced profile. You get pressor effect, you get a little bit of cardiac output. Epinephrine has a little bit more cardiac output because it has more beta. So this is a table you'll have in the recording. And note, I didn't make it comprehensive. There's a lot of other drugs, a lot of other receptors they hit. Just want to have a general profile. Your job here is to know a few agents, and depending on your patient, to combine these drugs into your regimen to achieve your goals. And you may actually think about reducing the max dose of one drug and using a second drug so you get synergistic effects with less side effects. Here are some other thoughts on this. So if we think about phenylephrine, it's a pure alpha drug. If you increase alpha tone and vasoconstrict, that often has an effect of reflex bradycardia. Based on baroreceptors, the heart rate will tend to be pushed down. Norepinephrine has the same effect on causing reflex bradycardia, but that's combated by its endogenous beta-1 tone. So you don't tend to see reflex bradycardia with norepinephrine. Let's contrast these agents in cardiac output. So phenylephrine increases the work of the heart. You're increasing the afterload or the pressure against which the heart has to pump. So that actually puts work on the heart. So if you have a potentially compromised heart, that may not be good. Whereas norepinephrine supports the heart a little bit with giving it some beta-1 tone. This is an area of active scholarship, and if you just look through the New England Journal, you will see every few years a mega trial on vasopressors. And here's two of them. One is the VAST trial. This is the trial from about 12 years ago. They looked at septic shock, about 800 patients, and they compared norepinephrine at a dose of 5 micrograms per minute or less to addition of vasopressin or norepinephrine on top of that. The trial overall did not show a difference, but in a subgroup analysis, vasopressin may be actually worsened outcomes, or at least did not improve them in the more severe group. But in the group that was on norepinephrine of 5 to 14 micrograms per minute, addition of vasopressin actually reduced the rate of death at 90 days. The SOAP2 trial was a larger trial, but it was unselected shock. So they actually had patients with mostly septic shock, but about a sixth each of cardiogenic shock and hypovolemic shock. And their comparison was dopamine versus norepinephrine. What they found in the dopamine group was that more patients needed rescue open label norepinephrine. There was twice the amount of arrhythmia, which was supraventricular mostly, but some ventricular arrhythmia. And then in the cardiogenic shock subgroup, dopamine was actually associated with a statistical significant increase in the rate of death. These same authors did a meta-analysis, which was about half the patients came from their trial. And in that group, dopamine actually increased the rate of mortality in septic shock. So this line of investigation is translated into some guideline recommendations to avoid dopamine in these scenarios. There's been a large Cochrane review. I didn't put any of the graphs or forest plots from that paper, but of the multiple comparisons, of which most were done of some agent versus norepinephrine, there's no overall difference in mortality, but they did find, again, adverse signals of the effect of dopamine versus some other agents. And the authors conclude that selection of vasopressors could be better individualized, not a lot of guidance in there, but again, they want you to think about what's available at your institution, what you have experience with, what are the pharmacologic beneficial side effects and profiles. So here's a summative slide referencing my experience, our hospital experience, and other guidelines. So again, for the most part, we're going to probably be seeing septic shock. If you have a patient with a normal heart or no reason to suspect an abnormal heart, your primary drug is going to be norepinephrine. As you monitor and treat this patient, you're going to think about using vasopressin in combination with that. So what does this do again? This is derived from results from the VAS trial. And what we're trying to do is to get some of the pressor effect on the vasculature while sparing some of the catecholaminergic, maybe beta effects and the effects of higher doses of norepinephrine. So you're going to possibly combine these two agents. As a second line, you might consider norepinephrine. Some of you may have practiced around the world. Epinephrine is used a lot more commonly than norepinephrine in other parts of the world, and certainly compared to MGH. If you need a third agent, then I would add phenylephrine, but probably after you've exhausted this combination. In the SCCM Surviving Sepsis Guidelines, it's worth a read. It's now published in Critical Care Medicine. It also has executive summary tables. Or if you look at the MGH guidelines, which are available on the MGH Medicine COVID Hub, these recommendations are the same. Norepinephrine, add vasopressin. Epinephrine can be considered. Both recommend against dopamine for the reasons we saw from the trial and meta-analysis data. Now, some of your patients may have an abnormal heart at baseline, or you may be concerned about the development of a septic cardiomyopathy. In that case, norepinephrine is still a fine workhorse first-line agent, but you're going to have to then consider adding an inotrope. And I'll have a slide later about how to titrate and pick inotropes. So you may add dobutamine, you may add norepinephrine. If you have overt cardiogenic shock, and here are mainly left ventricular systolic failure, realizing that there's quite a pleiotropy of etiology of cardiogenic shock, valvular, arrhythmic, restrictive. So norepinephrine is a fine first agent, but then again, you're going to focus on the inotrope, whether it's dobutamine, or epinephrine. I'll come back to that. The only scenario where you may consider using dopamine is if the patient has a bradycardic etiologic component to their failure. Some of the cases you may see, PE and tamponade, there's no guidelines. There's very little data on what is the optimal vasoactive drug regimen to use in these scenarios. And so it's really hard to distill that into a slide. If I had PE, I might consider inotropic support, and I may need some pressor support. And tamponade, if you have hemodynamically significant tamponade, just thinking about pressors, you obviously need to relieve the obstruction, not so much focus on the elegance of your regimen. Use whatever you have. So I have a patient on a regimen. Now my job at the bedside in the ICU is to continually monitor them. So we did our preload assessment and optimization as per Dr. Frank. You are going to be at the bedside with your team, restoring perfusion pressure, watching the pressure, and continually monitoring them. So are we seeing lactate clearing? Is the mentation changing? What is the hourly urine output? How does their skin exam look? And if I'm doing well and I'm maintaining my MAP goal and I'm seeing evidence of perfusion improve, then I can continue. And here are some, this is like Walter O'Donnell's Digilist. These are some things that I always think about. So as I'm watching my patient in the ICU, I'm trying to make sure Am I giving them a complication from this regimen, and can I adjust the regimen? So many of the drugs can cause arrhythmias. Actually, epinephrine can cause an increase in lactate. This is an effect of its other receptor function, beta-2, on peripheral glycolysis, which can result in production of substrates like pyruvate, which then are converted into lactate. Some people have actually theorized that maybe this is a beneficial effect of epinephrine because it provides a fuel source for the heart, but it certainly confounds our ability to read the lab and assess lactate clearance. So be particularly aware of that with epinephrine. Many of these drugs, by effect of having receptors in the mesenteric vasculature, can cause gut ischemia. So it's something you always have to think about, and think about your patient in front of you. Do we know if they have peripheral arterial disease? And if I'm squeezing their arterioles more, am I cutting off blood flow to the gut, which could be a source of lactate? Similarly, these drugs can precipitate myocardial infarction. Most of these drugs, I suggest that you run centrally. Your ICU pharmacist will be critical partners and resources in this. Some of these drugs may need to be run peripherally, and I confirmed last night with our pharmacist, all of these drugs can be run peripherally with different doses, but if you do that, you run the risk of extravasation. And in that case, it requires therapy to reverse the side effect of the medication. Vasopressin can cause hyponatremia, epinephrine can cause hyperglycemia, and all of them can cause digital ischemia by vasoconstriction. Let's say your strategy is not working. So what are some things that I always think about? So one, make sure the drug is getting into the patient. It sounds silly, but is the pump on? Is the IV leaking or not? Is the medication hanging the right medication? So we've all seen cases where the medication was not right. So it's worth a check with your nursing team and your colleagues to make sure. Acidemia will destroy the ability of some of these agents to work on receptors. Remember, a lot of these drugs are working by supporting smooth muscle vasomotor tone. If you don't have the metabolic and mineral substrate to do that, so if they're hypocalcemic, the pressors probably aren't going to work as well. And then always have an index of suspicion for what else am I missing? Does this patient have an occult endocrinopathy or cardiomyopathy or obstruction that I'm missing? And that's why my regimen to treat septic shock is not working. You may have read in some lay press and other trials about what other things can we do. So this trial came out right about the turn of the year, and they.
Quick question, Dave. There's
Sure,
a
sure.
question in the chat. It says, "What's a type 2 MI for those who are not adult providers?"
Oh, great. So type 2 MI, really you can summarize as demand ischemia, which just means a relative imbalance in blood supply to the heart versus the blood demands. So you can imagine that the blood demands of the heart are going up a lot because the patient's in shock, and you've also then increased myocardial work by giving them this pressor or inotrope. So this is just, you can think, this is just the parlance for demand ischemia. Type 1 MI is your acute coronary syndrome. A plaque has ruptured, you have a clot in the artery. Is that okay, Laura?
Great, thank you.
Okay, yeah, good question. So I'm just coming back to, this was the vitamins trial, and they had a cocktail of steroid, vitamin B1, and vitamin C. It actually makes some mechanistic sense. Vitamin B1 is actually involved in some enzymes. I know some of you probably hate biochemistry, but that actually clears lactate, so that may make sense. Vitamin C is actually a cofactor to convert dopamine to norepinephrine in the body, but this trial did not show a decrease in mortality or septic shock reduction. If you have a patient who's on skyrocketing doses of multiple agents of vasopressors, there are other ways to extract the peripheral pressor effect. Angiotensin 2, methylene blue. I think if you're starting to exceed doses of normal pressors, this would be a good time to get consult from your ICU pharmacist and or the critical care consult team with you. But there are other ways to do this. But it may mean that you need to have other supports. Think about ECMO and other supports. So let's say you're watching your patient and you're getting a suspicion that I can't maintain my MAP, but I'm wondering if there's a cardiac problem. So what should you do? Well, again, we're all judicious about minimizing tests and having a test that changes management. But if you're suspicious because they're cold and clammy, the pulse pressure is lower, or what have you, you may consider some biomarkers. This was one that we had in Nelson 9 a few weeks ago. And over a few hours, the troponin trend was up. That led to an EKG, which showed some abnormal changes in lateral leads. That led to an echocardiogram. This echocardiogram shows almost no contraction of the heart. The EF was about 5% on this. And from central venous access, we showed that her oxygen extraction was extremely high, which meant that blood flow was so insufficient that the peripheral vessels were taking out everything they could from the blood flow. So this is a way of saying if you have suspicion of inadequate central generation perfusion from the heart, you can consider biomarkers, electrocardiogram, POCUS or echo, and then central venous oximetry, which can help you differentiate septic versus cardiogenic shocks. Cardiogenic shock will tend to have lower central venous, or if you had a PA line for some reason, a mixed venous O2, and you saw hers were in the 30s, you and I should have a central venous O2 in the 70 range or a mixed venous in the 60 range. Hers was critically low. If you have that type of patient, I think it's definitely worth considering consultation from the cardiology team or the shock consult. This can be reached by 29159, which is our cardiac intensivist / ECMO team. It's the same person. And then you may need to consider an empiric inotrope at this time. So here are just a couple of things that I think about when selecting an inotrope. So all of these will increase force of cardiac contraction. But if I also need concomitant pressor because the patient is hypotensive, that may tend to favor epinephrine because the other ones tend to be vasodilating. Let's say I have a problem with the RV though. Milrinone is our choice there mostly because milrinone has a dilating effect on the PA. I avoid milrinone, or at least I'm cautious with it in renal clearance. The normal half-life of milrinone is 6 hours, but in a patient with fluctuating and deteriorating renal function, that could extend past a day. That makes it very hard to titrate. I mentioned the effect of epinephrine on increasing lactate. All of these cause heart rate increases. So it's tough to put some of these on when your patient's already having a heart rate of 120, 130, but you may need to do that to augment inotropy, and that may actually lead to a decrease in heart rate. Some last sort of miscellaneous things, glucocorticoids may come up in this lecture. Many trials on this. In our general practice at MGH is we don't give augmented adjunct glucocorticoids unless we have a specific reason. So unless the patient's respiratory failure mode is due to some underlying pulmonary disease, unless we know they have adrenal insufficiency, there's also some practice and data on pre-extubation to reduce stridor. I will note that the SCCM guidelines do allow you to consider it for refractory vasodilatory shock. We don't tend to do a lot of that here, but everybody's practice is different and certainly worth considering. Transfusion is something that may be considered. I don't have any specific data on transfusion support in COVID-19, and just remember that our blood bank supplies are very limited because blood drives are not happening. And then this pathway, the renin, angiotensin, or aldosterone system, has received a lot of press about are these bad or good in COVID because there may be some structural relation of ACE2 to the spike protein and how it gets into the cells. If you have a patient who's hypotensive or is about to be hypotensive, I think it's reasonable to hold that in general. But if you have a otherwise stable patient or an outpatient who's on a guideline-directed medical therapy for heart failure MI, most recommendations, this was a consensus from the Brigham, and then this is some data that came out of China. These patients, there's no signal that they're doing worse with it, and probably would be worse to try to change their medications without a good reason. So in summary, know the differential diagnosis of shock, know what it is, know how to monitor it, think about the types of shock you will see in COVID-19. Based on that thinking and what your patient's in front of you, think about what receptors, what physiologic goals you need. As a crib sheet, norepinephrine is always a good first line agent regardless of the type of shock, but whatever you're doing, you want to continually monitor your patient, monitor their perfusion, monitor their MAP, monitor for side effects, and always in the back of your mind think about, am I missing something else? Are they developing a comorbid cardiogenic or other component? So that's it. We'll take some questions.
Yeah, if anyone has any questions, oh, there's a couple up here. 2 quick questions. One was, are the max doses of, what are the max doses of the common pressors? And 2, have we had any issues running out of certain pressors?
Good morning, Carrie. I had all the doses in and then I took them out because I didn't want to be so boring. I could probably put that in as an appendix table, but so for example, phenylephrine, so everything runs generally on a micrograms per minute scale with the exception of dobutamine and dopamine, which are on micrograms per kilogram per minute. And so some numbers to think about. So phenylephrine, we're generally going to start somewhere in the high double digits probably. It's sort of like a 50 to 100. If you read prescribing information, phenylephrine probably like 300 is the max, but at MGH I've routinely seen in the many high hundreds, even 1,000. So hundreds of micrograms per minute. Norepinephrine, some hospitals dose it in micrograms per kilogram per minute. We typically use micrograms per minute. A typical start is 1 to 4. A truthfully, objectively high dose is probably 10, but we're very blasé to that at MGH because that's a common dose. I'd say 20 is 10 to 20 is still pretty high. I have seen doses as high as 100, but it's sort of like a single digit to low double digit would be sort of working to a high range. Epinephrine will generally be started at 1 microgram per kilogram per 1 microgram per minute. Doesn't get much higher than the mid-single digits. 10 is probably the accepted high range. Milrinone starting dose 0.1 milligram per kilogram, sorry, 0.1 microgram per kilogram per minute. Generally goes up to somewhere about 0.375 microgram per kilogram per minute, and it's titrated in increments of 0.5.
Dave,
Dobutamine.
would you
Yeah,
mind repeating the epi? Your voice kind of cut out for a second.
sure. Epinephrine, 1 microgram per minute is about a starting range. We will not infrequently when we use it, 1, 2, 3, 4, but not much higher than that, though it can be used as high as 10, certainly for anaphylactic shock or something like that. Milrinone, I think you heard. Dobutamine is generally in the microgram per kilogram per minute range. I generally don't use dobutamine under 2 because that's where it seems to be that the beta-1 effect under that is not seen, and I'm using it for its beta-1 effect, not its beta-2 effect. So dobutamine is generally like a 2, 3, 4. Can go a lot higher, but we haven't used it that much higher than that. And then dopamine, those were on the slide. So if you're going to use dopamine, it's going to be in the single-digit range. Less than 2 to 5, you're going to get mostly dopamine. You need sort of the 5-ish to get beta effects. Above 10 is where you're going to get alpha effects, but that's not the best range. Like, you're going to get more side effects from tachycardia than you're actually going to get alpha pressor effect. So maybe I should have put that slide in, Carrie.
The next question is, when adult patients are both on norepinephrine and vasopressin, why is it practice to typically titrate the norepinephrine and leave the vasopressin alone?
So in most practice, vasopressin is not titrated. There's a lot of papers on vasopressin deficiency and shock. And so if we put that on, we generally leave that on. And so I would say the way I would do it, if I have a patient who's on low dose norepinephrine, and then I'm getting a little higher and I add vasopressin, I'll see what happens to the norepinephrine kinetics. And then when I'm on my way down titrating, I would probably leave the vasopressin on until I'm getting close to norepinephrine being off, something like 5, somewhere in there, plus or minus. Then I will just stop the vasopressin. I'll make sure that that's, I'm able to stop that and the patient's still okay. And then I will titrate down the norepinephrine. I know, Laura, you can comment on that, or I saw Kyan before. That's what I would do, and that's
yeah, that tends to be my practice too. I think the question kind of is like a little bit about why, but I think that's mostly, as you kind of alluded to, like that's how it was studied. Is that your understanding as well?
Yeah, and I'm just looking back in the chat about I missed a question about have we had any issues of running out of pressors? Not that yet. You've all seen that we've had shortages of cisatracurium and other things. I've not seen that we've had a pharmacy bulletin or even communication about an impending shortage. Somebody else on the call may know better, but I do not know of a shortage of a vasoactive agent at this time.
I haven't heard of any either yet, but we'll keep a close eye. These are all great questions. Any other questions for Dave before we bid adieu?
Okay. Thank you, everyone. Thank you, Laura.
Thanks. Everyone have a great day.